Hmm. Well, Hello. 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 Am I audible?
Yes, you are.
किसी को नाम से कह दिया था की सोच रहे दूसरा जवाब दे रहे ना आप अपने Hi Tejas, are we audible?
Yes, sir.
Yes,
Anyone can confirm, are we audible? Hello.
yes,
Yes,
we
sir.
can hear you.
We can hear you.
ये वरुण क्या कह रहा है?
Dr. Shobhit, they can hear us.
They can hear us, but we can't hear them. आपको अपना साउंड आउटपुट you can make it to the TV का sound. Now.
ये लेटेस्ट है तो पेंडिंग में टीवी का टोकन जा रहा है तो ये चीज जी यहाँ से तो सही आ रहा है यहाँ पे ओवरराइड हो रहा है
Hello. Yeah, good afternoon, everyone. I hope we are audible.
अपने पास एक स्टोर करके रख
Yes,
दिया
we can hear you. Yeah.
Okay, so thank you all of you for joining. I'm Dr. Shobhit Rastogi. I am joining from National Health Authority. And as you all know, we are here to discuss a new initiative that NHA has sort of believed in and is going to implement very soon. And that is regarding a clinical decision support system that has been developed by All India Institute of Medical Sciences, New Delhi. And that CDSS has been in the works, has been under discussion for some time now, and now we are ready to sort of go forward with this engagement and start the integration journeys of our HMI solutions. So today we are organizing this webinar to let you all know what would be this whole project and how you can participate in this important program. Today we have the AIIMS CDSS team with us, a very distinguished professor, Dr. Tandon with us. He's the HOD of Endocrinology Department at All India Institute of Medical Sciences, New Delhi. We are fortunate to have him with us today. And along with him, there is Dr. Dave Jindal from the AIIMS CDSS team. We'll be hearing from them regarding this whole CDSS. So there will be 2-3 things that we need to focus in today's webinar. First is, what exactly is this webinar? What all it can do? Why NHA has believed in this CDSS, in the potential of this CDSS, and then how to be part of it. That would be the second and most important part, because this CDSS would be able to reach out to people and serve its objective only on top of an existing HMIS. So that is where you all come in. You have to integrate with the CDSS so that the benefit of it can be provided to the general population. So without much ado, I would open the stage for Dr. Dev Jindal to initiate the conversation, and thereafter our professor. Okay, I've just been told that sir is ready to join. So initially also I would request now Professor Nikhil Tandon to please say a few words and introduce this clinical decision support to all of us. Sir, please.
Thank you, and sorry for changing the initial proposed sequence. So I'm just going to give you some sort of a conceptual overview, and then the technical part will come in later. This work actually is about No, yeah. So this is really a work which we started in 2010-11. So what I'm trying to say is that the whole evolution of CDSS, the formal testing of the CDSS through formal research design, and then its integration into the health system already as it stands today, is a fairly mature journey. So I'm going to just take conversation into 2 parts. One is why we decided to go down this route. I'm an endocrinologist, and basically we were trying to look at strategies to improve the quality of care delivered to people who have diabetes at the level of clinics, right? And we had the following logic flow in our mind, that we know that people with diabetes have an abnormal glucose. A lot of them have a high blood pressure. A lot of them also have an abnormal cholesterol value. We have medication available for diabetes in terms of glucose lowering, oral and injectables. We have tablets available for blood pressure, and we have tablets available for cholesterol. We know that if you bring the levels of these parameters, whether it's hemoglobin A1C, which is the average glucose over 3 months, or blood pressure or cholesterol, we reduce the likelihood of complications of diabetes. So this was our knowledge base. The global data, I'll come into data later. And if you take 100 people with diabetes in the US today, which is supposed to be a developed country with a sort of highly evolved health system, only between 20 and 22% of all people with diabetes achieve all 3 targets of control. That is the hemoglobin under 7%, less than 50, systolic blood pressure less than 140. In India, corresponding data is 8%, right? So when we know the problem, we have the medication, and we know what should our aim for control be, despite that we're only down to 8%. So that's where we started, and we started by creating an intervention package which comprised the following. Remember, this was done in 2011, and therefore we had health record, which was not so commonly available in those days, which was integrated the clinical decision support system and a non-physician healthcare provider to assist with the implementation part. I'm not going to go in much more detail, except to say the following now, that invention, when we were involving nearly 12 across 10 clinics in India, North and South, public and private, we were able to demonstrate that the likelihood of multiple risk control increased twice, in fact, even more than twice as much, if we use this strategy of the electronic health record with the clinical support. We also have a sub-analysis project that to compare people I can continue. Okay. I'm not sure if this was, if you heard what I said, but anyway, I'll just repeat that very briefly. That since this was a randomized control trial, we could also analyze what happened if to the control of people in whom the physician had accepted all the recommendations of the CDSS versus those in whom it was not, and there was a significant benefit. We then went on from tertiary care to demonstrate this in primary care settings and in secondary care settings. So the first sort of transition for us was the first transition for us was then when the state government of Mizoram and Tripura included our package of electronic health record and clinical decision support software into primary and secondary care governmental institutions. So from being implemented in individual clinics, it went directly to a health system. Since then, we have now also implemented this at district level in Punjab, in which all healthcare facilities, primary, secondary, and tertiary in a block were compared to those in which it was not. So essentially, all I'm trying to communicate to you is that this CDSS has evolved, matured, and has been evaluated at primary care, at secondary care, at tertiary care, and at integrated health system, which is a combination of primary, secondary, and tertiary care. And we've increased and improved the functionality as we go along in terms of how we can improve the suggestions, what we can do about referrals, what we can do about research referral facilitation. So if it's a multi-tiered system, how do we ensure that this person needs to be referred? How do we facilitate that? Up referrals, down referrals. The CDSS contains incremental prompts for changing oral medications. This now also has recommendations for insulin initiation and insulin dose titration. So it really covers the entire spectrum of care. At the moment, the versions that we deal with are primarily for blood pressure, blood glucose, and cholesterol control. But I'd like to inform the group that we have developed, but waiting for testing for other comorbidities and conditions, including chronic obstructive pulmonary disease, depression, osteoarthritis, and even maternal and child health. But that is not at the moment integrated into the package because we perform fairly rigorous clinical level testing before we like to release anything into the public domain. But whatever we are now sort of sharing with you, as you would have heard from me, has been formally tested with rigorous sort of statistical design and research design and published, so it's available in the public domain. So everything is out there in the open. And if you want to independently review that information, the impact of this CDSS is available in the public domain. We don't have to provide it to you. I just want to close my bit with one remark. The holy grail for diabetes is not merely demonstrating that I could control somebody's sugar better or cholesterol better or blood pressure better, but that I reduce the likelihood of an individual to get a complication. Complications in diabetes include those which affect the smaller vessels. So there could be the retina and therefore blindness there, kidney, therefore kidney failure, nerves, and then the larger vessels which can affect the heart, the brain, and the supply to the blood. We have just released our data and published it. And again, this is available in the public domain, which has shown that the very first study that we did in tertiary care, we continued that for 6.5 years and now demonstrated that with this intervention, we have managed to reduce the likelihood of complications by 30 or 35%. And that's what's coming on the slide. I'm sure Dave will talk to you about this in more detail. But again, showing that we have gone ahead from showing a benefit on intermediate level outcomes, which is controlling the biochemical and blood pressure parameters, to actually hard clinical endpoints, which is a massive demonstration in terms of what the CDSS promises anybody who takes it up. I'm going to stop here. Maybe Dave, you should take up the formal presentation. I just gave it a snapshot, and then of course, in due course, we can come to responding to any queries or clarifications that are so required.
Thank you, sir. I think most of my slides you have already covered in this talk. But going ahead, thanks to the NHA team for introducing AIIMS CDSS to all the digital health platforms who are ABDM compliant. Most of you are already aware about clinical decision support system, and since we are in the technology space, we know how CDSS work, and the definition of clinical decision support system is a very broad definition. Most of you might have already encountered different types of clinical decision support system. But this clinical decision support system is different from other CDSS that probably you might have seen, because it provides a patient-specific recommendation. So when I say it provides a patient-specific recommendation, it has been designed in such a way that our doctors who are working in the Indian healthcare settings, they get the patient-specific recommendation in very easy to read and very easy to implement way. So they get the correct dosage, drug name, class name, what should be the follow-up, what are the contraindications. So everything in a very concise manner, so that the doctor, they don't need to spend much time on that. So, and it also provides patient-specific recommendations. So it is designed for individual patient clinical parameters. So it will not give you a broad kind of recommendation where a doctor has to spend or healthcare provider has to spend a lot of time to understand, read, and then make a decision. But it helps them in getting the exact based on the patient profile recommendation. Then, as I said, it also provides the information about the contraindication, what drug should not be given to this particular patient. So it improves the patient safety. And it also helps in prescribing the drugs which are required for preventive measure. For example, if you have to start statins or aspirin for cardiovascular disease at the early stage without any cardiovascular event. So that kind of intelligence is already built within the system. And then it also improves in workflow. So what it means, because you all are again part of the digital health ecosystem, we have seen the doctors, sometimes they are reluctant to enter multiple medical history or EHR records in the system. But if we offer this technology, there are high chances that they will involve some of their paramedical staff in creating the EHR record for that particular patient, and it will help the healthcare providers in utilizing the CDSS in a much better way. Dr. Shobhit want to say something? Yeah.
Just switch on the camera and select Panasonic. Yeah, Panasonic basic.
Blur background.
Please go ahead. Thank you.
So now you can see us all as well. So, and just one more thing. So this clinical decision support system has been, as Dr. Tandon was explaining, it's more than 10 years now. I think it's almost 14 years of work that two big organizations in India are working on this CDSS. We started with hypertension and diabetes. Now a lot other conditions have been included in the CDSS journey as well. And so this CDSS is thoroughly researched, has been validated through many projects, and we'll talk about it later as well. Now, why do we need clinical decision support system for our country? Because we might have seen thousands of patients around us with hypertension and diabetes, and we might have seen people having heart attack or stroke at the early stage in our country compared to if we compare our data with the Western countries. So that's why there is a huge need that we need to focus on these conditions, which are very prevalent in India. And we believe that doctors, they are fully trained. They obviously want to do best for their patient, but simple technology like clinical decision support system can assist them in bridging the gap, in bringing the science to their practice. So whatever the evidence says, because sometimes the doctors, they are super busy, they don't capture the medical history properly, or they don't look at certain other parameters, but technology like this can help the doctor in providing the best care to their patients. And as I said, like it provides the personalized treatment plan. And then when you're going to integrate clinical decision support system with your technology, you are also going to tell your user base that this technology is basically designed to assist you, and it will empower your other colleagues within the hospital setup, and it will overall improve the patient care and patient follow-up. So definitely there is going to be improvement in the clinical workflow, and also the number of patients who are going to visit these clinics. And this is all backed by the different studies and different data sets. Now, for a company or for any digital health provider, why do they need clinical decision support system? So we just talked about the clinical outcomes, the patient side of the benefits, but as a company or as a platform, what are you getting? So one thing is, obviously you're getting the branding from NHA and AIIMS, and the technology which is being offered has already been endorsed by many medical and scientific authorities like World Heart Federation, Indian Council of Medical Research, and also the government of India in various programs. They are already using this technology. Then competitive advantage. So whoever is going to adopt this technology will be one of the first technology which will be offered at the OPD settings or at the clinical settings. If you might be already aware about a lot of the companies in the Western world, or a lot of hospital or healthcare settings in the Western world, they're already using clinical decision support system in their practice. So if we introduce this technology through FDM compliant solutions, so we'll be the first one in India to use this technology, and you will be first one to have the co-branding from NHA and AIIMS. And as I said, it improves the workflow improvement, and it will ensure that more and more patients visit that health facility, because it also has the functionality to advise the follow visit and also advise the more clinical test. And then we also talked about clinical management and diagnostic support. But this technology, as of now, is being offered from NHA to only to the M3 compliant digital solution companies. And from the patient workflow point of view, this is just one scenario when we're talking about a workflow, how this technology can be integrated within your EHR system. So when the patient walks into the health facility, if someone, or if in any hospital or healthcare setting, someone is using a digital platform, what they need to do, first the patient can go to a nurse or any receptionist. They will do the initial assessment. So this is the flow which we suggest, because it is just a simple medical history from hypertension and diabetes point of view I'm talking about. It's just a simple medical history. They will just check whether they already have any medical condition, non-medical condition. They will enter their blood pressure values or blood sugar values if it's available. And CDSS will analyze the data. And when the patient goes and see to the doctor, doctors will already have a prompt on, or whatever way you want to present this information to the doctor. They will have a brief profile of the patient along with the CDSS recommendation. So it will not waste doctor time in capturing the medical history. So you can share a brief profile with recommendations. So definitely it will add value to your product. Because now, most of the time, what we have seen, doctors, they don't want to enter anything in the EHR because they just think it's a medical record. But if they know that something will come out of these EHR records, and they will be able to use this recommendation in their practice, they will be able to have increased follow-up for their patients. We believe that it will help in adoption of your technology at the health records point, from the health records point of view. And this is one of the study which Dr. Tandon sir already talked about, because most of the research that we see and we read, it's mainly again from Western world. But in this particular study, if you see what we have shown, if you use this technology along with some task sharing concept, there is definitely reduction in the HbA1c value, systolic blood pressure value, and cholesterol values. Along with that, what we have seen that as Sir talked about microvascular events and vascular events. What it meant, like we already know that diabetes and hypertension condition like these, they affect your eyes, they affect your kidneys. So if we give evidence-based treatment to the patients without doing any, like, without thinking about that we need to invent new drugs, but just using this technology and just using the science in the practice, we can see reduction like 32% and 28% in their events. And this is one of the studies. So the researchers from AIIMS and CCDC have done multiple trials, multiple studies, demonstration projects, and all of them have shown improvement in the clinical parameters, increased follow-up rates, and there is also an increase in adoption of the technology by the doctors. So all these things are very important when we think from the ABDM perspective, that definitely now most of the companies are ABDM compliant, you all are ABDM compliant, but whether the adoption of EHR is going the way we want. So we believe that technology, if we integrate this technology, it will also help in adoption of the EHR by the doctors. And this is a simple process that if you all are interested in integrating or using this clinical decision support system as part of your platform, you need to show your interest to NHA team. We'll organize a detailed orientation session for the for interested parties. We'll give them a demo, detailed demo, how the API variables works, what are the input and output input and output variables, and what kind of potential UI changes you will require. Then we'll share the API documentation and sandbox credentials with you. Then we'll also assist you in making the UI changes. Obviously, you will have the final call, how you want to show the CDSS recommendation, how do you want to capture the variables required for the CDSS to work. But we'll be there to guide you, what can be done, what looks better from the clinical perspective as well, and how the doctor would like to see the recommendation from that perspective, but you know your product better than anyone else. And then once you're ready, then the last step is to move to the production environment. So one of your colleagues have already integrated the clinical decision support system with their platform. It's +91 team. And we want more and more DSCs to join the clinical decision support system movement. And then if you want to be part of it, please write to us, or maybe you can contact Dr. Shobit or Dr. Amardeep. Thank you.
Stop sharing.
Video.
Thank you, Dr. Dev. That was a great introduction about the CDSS, and I'm sure you now know why NHA is standing firmly behind this CDSS and putting it across for all of you to integrate and provide its services to the patients across the country. Now, I would request our director, Shri Vikram Pagadia, sir, to please say a few words about this engagement, sir.
A very good morning to everybody. It's just 12. Oh, it's 12:30. Very good afternoon to everybody. We are very hopeful that you would show interest in the CDSS. What NHA has tried to do, along with the support of AIIMS Delhi, is that we want to roll this CDSS as a digital public good, because many a times we are asked, what is this? What is the benefit that a doctor, or what is the benefit that a hospital is getting out of digitization? And we have seen that doctors who are overworked, doctors may overlook something, or maybe when they are writing their prescription, they get some prompts, and so they are able to better provide healthcare delivery to the patient. With this intention, we have put our force behind this CDSS. We have launched it as a digital public good for NIC, for CDAC, and for +91, the plus 91, the integration is complete, and I see CTAC, the integration is going at a fast pace, and it will be completed soon. And we have opened this CDSS for all ABDM enabled solutions. So we will request you that you would want to know more about this product, you please contact us, take advantage of this digital public good, and help its the efforts that AIIMS has put in preparing this digital public good at least reach to the intended objective is achieved. So thank you very much, and we look forward to your participation. We have a small video which shows how the CDSS works. So Dr. Dev, over to you.
Thank you, sir. If anyone has any questions, they can ask us, or maybe you can take it after the video as well.
Yeah. वो शेयर साउंड करना पड़ेगा.
तो उसमें साउंड है नहीं, मुझे एक्सप्लेन करना पड़ेगा. So I will explain.
आप ही बोलेंगे. But
so this is one of the example where we have integrated the clinical decision support system with the national program for non-communicable disease. So this is the government of India staging version. Obviously, I cannot use the production version for the demo. So like any other HMIS or EHR platform, there might be different way of patient enrollment. So there is a simple way of patient enrollment for NP NCD patient. So once the patient enrollment is done, and if any solution is ABDM compliant, they can use the scan and share method also. So this is what we are talking about, the initial assessment part. Here what we advise any paramedical staff, nurse, or someone from the clinic can enter or check the blood pressure of the patient. They simply need to enter certain parameters. And one of the important thing when we share the CDSS variables with you, there is an list of variables, but not all the variables are mandatory. For example, we have just entered the random blood sugar value. We could have entered the fasting and HbA1c also. So this particular patient, in this particular scenario, what we are showing to you, the patient comes to the clinic and he or she doesn't know whether he or she has hypertension or diabetes, only with the medical history of COPD. And the patient is not taking any drug as of now. They just have the medical history of COPD. And the doctors, they can review what the nurse has entered. Now, this is the diagnosis part. The CDSS recommend the patient has hypertension stage 2. Doctor can agree or disagree. Now, if you look at the notes part, CDSS is also recommending the beta blockers are contraindicated. Then the CDSS is recommending the class of the drug which should be recommended along with the generic name and their dosage, and also the follow-up duration. So we talk about the generic drugs. We don't recommend any brand name as well. Again, the doctors, they can accept or reject the recommendation. Now we are going to the diabetes scenario. Again, according to the clinical decision support system, the patient has diabetes because the glycemic control is insufficient. Once the doctor confirms the diagnosis, they go to the next page where they see the medical recommendation that we need to start with the metformin 1000 milligram along with the follow-up. So this was a small video which we have created just to show one scenario. But there will be multiple scenarios, and the CDSS will recommend will give the recommendation based on the clinical profile of the patient, and doctor has the final decision to make. And from the UI side, you can decide whether you want to have diagnosis, clinical notes, or treatment on separate page, or whether you want to have everything on one page, whether you want to have diabetes and hypertension on one screen or separate screen. So that all flexibility will be with your own product. And if you already have any existing AI capabilities, for example, we are working with the NIC, as Vikram sir said, and the CDAC team also, they already have certain AIs inbuilt within their platform. So it is not going to impact, or it is basically to coexist and enhance your capabilities. And as I said, from the UI part, again, the patient registration, capturing of the variables, it's all part of your product. Will be just there to assist you, help you in doing the integration. Thank you. Yeah.
Yeah, I mean, please, if any of you have any questions, queries, please feel free to ask. we have the entire team with us. We can definitely answer your queries.
Can raise your hands or speak.
This is Sethu Raman from Alsaf. Can you hear me?
Yes, we are able to hear you. Please
Thank
go
you.
ahead.
Thank you. This is something that is going to be very, very useful. CDSS is always, as you mentioned, this is something which is going to definitely help. My questions are a little bit trying to understand from the integration perspective itself. So I understand that the key whatever vitals and other stuff that is going to be collected by the platform, and then this information is going to be related to the CDSS module, which is then going to give the recommendations, those screens that you showed. So is this, I mean, especially when we are talking about it from a primary healthcare perspective, and let's say, is this applicable at all for the CHOs who are sitting at the Arogya Mandir at all? Because I mean, the recommendation part of it may be there because they are not going to confirm. So I was wondering, in case it is, how will it work in case of an offline setting? That is one question. The second question itself is, even let us assume that this is going to be at the PHC and the medical doctor is going to take care of the confirmation and so on and so forth. So this will essentially be a server-to-server communication, if I'm understanding this correctly, at the API level. So if you could clarify these points, that will be very helpful. Thank you.
So I'm going to answer this partly and then ask Dave and other members. So I think you raised very pertinent points. Let me first come to your question of the so-called health and wellness centers or the Arogya Mandirs. As of now, even today, prescriptive powers, as you know, are only given to a medically trained person, right? Prescriptive powers have not been devolved or delegated to the CHOs. They have dispensing powers, but not prescriptive powers. So you're absolutely correct that the CDSS prompt can inform, but the confirmation has to be done by a person who, by prevailing governmental rules, is allowed to prescribe. Now, whether somebody then wants to combine this with a telemedicine so that the CHO is having a conversation with a medical officer is a possible solution to that. We haven't worked in that direction yet, but that's an ongoing conversation. But I would again sort of just want to reiterate exactly what you said, that it cannot start and stop with the CHO, not because the other reason, but because the CHO is not allowed to prescribe, and the CDSS is a prompt or a recommendation which has to be accepted, modified, or rejected by the prescriber. So that's point number one. Point number two was it's rolled out at PHCs. So, you know, from a functionality perspective, it has rolled out at PHCs. And again, you're absolutely correct that it will require to reach a server and come back there to give the response. There is also what we did in Punjab was, because we wanted this information to be performed at not only at the at the facility level where the patient was being seen, but that it should be available to all doctors and healthcare professionals within that state's network because of the possibility of the patient being referred. And therefore, it needed to be an online mechanism. But if it's a standalone private clinic, you can create the same functionality as an offline version also, because the patient load is then limited to that clinic and there is no connectivity with a institution outside of that clinic. But so those are all things which can be considered. The way we developed it was primarily for an integrated health system delivery, where it is a multi-institution or a multi-facility health system, but it's easily doable for isolated standalone institutions also. I'm not sure if I've sort of answered your question fully, but if there's a follow-up, please go ahead before we request. I see another hand on the screen.
I think it was very clear. Thank you very much for the clarification. And if there are any follow-up questions, we will get back to you. Thank you very much, sir.
Yeah, Mohit, please go ahead.
Hi Shobit. Hello sir. I think it's great. I think it's addressing the top therapeutic areas. I had one question on I've heard the entire presentation. I've gone through the presentation. What are the false positive rates, or so to say the accuracy rates when it comes to the recommendation for this, since this has been already done in primary, secondary and tertiary care?
So here, I think what really needs to be clarified from our side is that there is no ground truth, right? So if you go to a doctor, let me rephrase that. If the same person goes to 5 different doctors, right? The 5 different doctors may give variations of the same prescription, none of which we are in a position to call the gold standard. As opposed to, let's say, that there are tests which have to be done, but a particular laboratory is considered to be a gold standard lab, and you compare it with that gold standard. So realistically speaking, there is no ground truth in that sense. However, let me now sort of take this a next step. What we did in the first study, which is the one which has been has been analyzed in the greatest detail, is because these are rule-based scenarios, what is the likelihood of a physician accepting, modifying, or rejecting a particular prompt, right? Now, that becomes very critical because it depends on what all the rules have captured and what is the information available and what are the variables which may impact decision-making. Let's look at just glucose to start with, and I'll maybe be able to clarify this further. So let's say a patient goes and the algorithm says that, okay, this person's already on insulin and on multiple medication, the sugars are not well controlled, and therefore the recommendation then comes to either increase the insulin dose or modify the medication, whatever it is. When the doctor talks to the patient says, in reality, doc, my daughter was getting married. For the last 1 month, I've been so preoccupied with that. There are so many days that I've actually missed my insulin. I've not been able to go for my walks, and my diet has been off-key, right? Now, those are the sort of scenarios which we really can't integrate into a rule-based thing. And the doctor will then say, fine, I will not up-titrate your medication. You have, the daughter's wedding is over. Let's give it another month on the same treatment, and we'll then reassess at that point in time. As opposed to blood pressure and cholesterol, in which our prompt acceptance rates were about 80 to 90%, whereas our prompt acceptance rates varied from 55 to 70% for glucose, for the reasons that I've specified. The reality is, whether those prompts were correct or not came through in our analysis of the impact on control, comparing those in which the prompts were being accepted versus those in which the prompts were not being accepted. There was about a 0.5, 0.6% difference in HbA1c. There was a 20 millimeter systolic blood pressure difference in those prompts related to blood pressure. and there was nearly a 35 milligram per deciliter difference in LDL cholesterol. So clearly saying that even if we don't call it a ground truth, we have a situation where there is an obvious measurable clinical impact. So, I mean, that's the way I would answer your question, as opposed to, going down the false positive, false negative stream.
Thank you. That answers my question.
We see another hand, Chintan.
Yeah, good afternoon, sir. Am I audible?
Absolutely. Yeah.
Yeah,
Go
thank
ahead.
you, sir. So I have one question regarding the, can we use this recommendation only for the like OP patients, or we can, let's say we have a EMR for OP and IP both. So can we use that on the IP patient also? As well as if what are the main recommendation available, like let's say if I have a lab reports available in the IP, do we have any recommendation on the basis of the lab report, or this is only for the medication part?
Okay. So really you can use it whether it's outpatient or inpatient, but let me just give you a little perspective about so if you remember, this was at the moment we're dealing with glucose, blood pressure, and cholesterol, right? Which are chronic conditions for which whenever you make an escalation in the dose, you normally don't, you wait for about 7 days at least to see the response. So the question automatically which will come is that if I have, let's say, changed cholesterol medication for somebody who is admitted in hospital, when should I next really reassess, measure the cholesterol, and then trigger the decision support? And most people will say, give it at least a couple of weeks, if not longer. Now, if a patient is going to be in hospital for that duration of time, it can very well be used without any difficulty. So for most oral medications, it depends on how soon you want to see the response to a change in dose and how reasonable it is. It's the same thing with blood pressure. For diabetes, your question becomes very pertinent because insulin dose can be changed at much more frequent intervals and actually can be changed on a daily basis. And for that, this particular CDSS, which includes insulin, will be easily adaptable and adoptable in an IP setting also, because it is logical and clinically appropriate to make frequent dose changes with insulin, whereas you normally wait for a little period of time before you make a dose change for oral medications, for whether it is glucose or it's cholesterol or it's blood pressure. So I think that was the first part. I think I've forgotten the second question. You had two questions. This was the response to the OP-IP part.
Correct. Or the second question was that can we let's say if a patient has a thyroiditis available on the patient side, and it's a T3, T4, TSH is almost let's say not recommended. It's not in a normal range. So on that part, can this recommendation would be used for the medications?
Okay. Okay. So quick answer to that is, at the moment, we've not done non-diabetes endocrine, right? At the moment, so it's in the interest of full disclosure and clarity, at the moment, this CDSS has been used primarily for glucose, cholesterol, and blood pressure control. But I think you've given us an important suggestion, and we would definitely go down that road also, because as I said, I'm an endocrinologist, and it'll be really helpful if we can, handhold non-endocrine primary care physicians to manage diseases like thyroid disorders. Thank you for that.
Thank you, sir.
And also in the orientation session, we'll explain the entire list of variables in what category, sorry, in what category you can have these variables. So we have medical history, we have drug history, we have clinical vitals as well. So in medical history, for example, if we are already recording the patient has certain conditions like asthma or maybe liver condition or kidney condition, then accordingly the CDSS will change the rule. It will decide whether this particular medicine is going to make any adverse impact on the patient parameters. Similarly, as sir said, we also talk about insulin, titration of insulin. Even if the patient has low blood sugar, is in the hypoglycemic state, even then the CDSS will recommend certain medication. So it takes care of the medical history, then it also consume the information if the patient is already taking medication. If we just imagine one scenario when the patient is coming to the clinic, they might already be taking some medication for hypertension or diabetes or maybe for the lipids. So it will also understand the patient is taking these medication and the patient blood pressure, blood sugar, cholesterol is not under control, then what should be the next decision? So there are multiple parameters which it will consider before giving a recommendation, and we'll share the entire list. Plus, as I said in one of my slides, it's not mandatory that we share all the information with the CDSS, because in the real world scenario, sometimes there is only blood pressure available. We don't have the random blood sugar with us. So even that will give some recommendation for hypertension.
So can I just quickly add also to what Dave said, and maybe in the interest of brevity, we perhaps had then. So one, obviously, the important part clearly is that it automatically will give a recommendation which is appropriate to the overall clinical picture, as long as that information has been captured by the electronic health record. So example, if there's a person with diabetes and they have mild kidney dysfunction and the creatinine is already captured by the electronic health record, it will automatically not recommend any of the medicines which would have been which are contraindicated in that clinical scenario. The second part, and I think it's important for all of those who represent a multi-tiered health system, whether it's, for example, a corporate hospital which has a main hospital but has got outreach clinics. So there are two levels of care, or sort of a family physician primary care level and a tertiary care level with specialists, or governments who have, with the state government, central government, in which there are automatically a hierarchical, so primary healthcare facilities, PHCs, CHCs, district hospitals, medical colleges. The important thing is referrals, right? Now, imagine I come from the All India Institute of Medical Sciences, and I keep saying that AIIMS serves like a primary health center for people who live near AIIMS, because, you know, people just walk in to show diseases and conditions which can easily be managed by primary care physicians, family physicians who are outside and managed equally well, right? In contrast, there are several patients who are unable to reach AIIMS because, you know, they didn't get an appointment, who are languishing at primary care level, which is unfair to them because their problems or conditions merits a tertiary care, this thing. Now, we've never been able to reconcile that. We can't force people to reach one place or the other, but we can ensure through a process of referral, you know, ensure or channelize it. So let's say a patient walks in to a primary health level and they are already on maximum doses of permissible medication. Let's say in a government and a PHC, there are only 2 medicines available for diabetes and their sugars are not under control. This will provide a referral threshold. It triggers a referral process. That information is not only informed to the patient that, you know, I think you need to see a specialist at a higher level. It also goes to that higher level within the hierarchy. So let's say it's in a district, that information will go to the community health center or the district hospital, wherever the referral has gone to. It will also go to the sub-center, where the ASHA A&M is informed that so-and-so patient has been referred. So they will encourage that, and the doctor at the higher level will be in a position to have that prior information to appropriately receive that person. Similarly, when you go up to the highest level of care and your condition is well managed, you can then be down referred to wherever you can give stable maintenance management, which is for which you don't need to go back. If you're just doing a repeat prescription, you can easily be sent back to the lowest level of care where you can be given or dispense those medication. So that process of referral has also become objectivized and standardized, and it's not left to the discretion of the treating team. I think Chintan has a follow-up to that. You're muted if you're speaking.
Oh, sorry. Sir, I have another question regarding the, let's say, the recommendation was given, and based on the recommendation, doctor said, doctor prescribed some of the medications to the patient. And let's say patient have some of the adverse reaction after that taking medication. So is there any chances that that recommendation would be available after the adverse drug reaction, or is there any any API or anything that would that we can maintain that this patient has an adverse drug reaction from the recommendation or anything else?
So if you recall, at the moment, the CDSS doesn't store any information from the patient, right? So at the moment, in the interest of data privacy, we are not getting information about the individual. We're just getting a set of parameters for that person. And on the basis of that, the recommendation goes back. So all the identifiers and all of that will be within the electronic health record or the electronic case record form of the system in which care is being sought. So yes, if the system then captures that based on a particular prompt, an adverse drug reaction was a consequence, that'll need to be informed to people like us, remembering fully, however, that an ADR for an individual does not necessarily mean that the recommendation is inappropriate. It may be a specific thing related to that individual or the condition of that individual, but nonetheless, it would be important to get that feedback. Automatically, the CDSS will not be able to respond the way you are saying, because we don't have the necessary information. All of that information lies with the health system. And the CDSS has been created so that any data privacy issues which have already been handled by the care provider or the system of the care provider are the only privacy issues which are relevant, because nothing else is going outside. We just get de-identified information, which basically which sort of triggers the engine to perform its task of giving a recommendation, and then it goes back to that. And so I hope I've made that sort of flow clear. But again, the point you raise is valid, but it will necessitate the system provider to give the feedback to the CDSS team.
Okay, thank you, sir.
Anybody else? So what we are going to do is we will share the presentation with you. We will also share a brochure with you. We'll also share the video that Dr. Dev showed to you. And we will organize another session, which is the orientation. We will inform you the dates and we will try to keep it in a hybrid mode, so that for those, if you are able to come over here to Delhi, I think it will be more effective. But if you are not able to do it, you can join online. So we'll let you know as early as possible. If you have any suggestions, ideas as to how we should go about implementing this digital public good, please feel free to share with us, and we thank you for your time. Thank you. Good afternoon. Anything else, Shobit?
No.
Thank you.
We have also shared the email address in the chat. For any query, any suggestion, any interest over the CDSS product, you can please write us on the given mail. We have given on the chat.
Okay. Thank you. Thank you. We'll make available this recording also on our YouTube channel and share with them. Okay. So
Thank
that
you everyone
others-
for joining.
Thank you. Thank you.
Thank you.
Thank you.
Thank you.